Good morning, everyone. I'm Claudia Zamora, a health education consultant and a health equity advocate. I serve on the board of directors of Women's Life and also on the board of directors for the National Hispanic Medical Association. Today, it is my pleasure to introduce Dr. Pedro Jose Greer. Better known as Joe, Dr. Greer joined the Roseman University of Health Sciences in 2020 as founding dean with the goal of establishing an innovative mid-21st century Las Vegas medical school that would align students, educators, and community in designing and delivering an inclusive and collaborative environment for learning, healthcare, and research. Dr. Greer, an American physician of Cuban descent and MacArthur Fellow, has been an advocate for health equity by engaging communities to create both effective and social policies and accessible healthcare systems. For his work, he was awarded the Presidential Medal of Freedom, the nation's highest civilian honor. Please join me in welcoming Dr. Joe Greer.
Claudia, thank you for those beautiful words. My mother wrote it. Hi, I'm, boy, these lights are bright. I'm Pedro Jose Greer. They call me Joe. I grew up in South Florida when it was a small white racist town. It's always nice to go back to a large Hispanic racist town. I'm a hepatologist, gastroenterologist by formal training. My interest has always been in social justice and making changes that are effective. I started off my career in academia, went into practice with my father, and then went back into academia almost 20 years ago. Being that about 20 years ago, I was sitting with my wife, and I said, I've never made so much money in my life, and I've never been so unhappy. I'm really unhappy with my profession, at least in South Florida, where we have twice the amount of Medicare fraud as the rest of the country combined. And we're not doing anything to take care of the most ignored, the most vulnerable of our population. We all have incidences in our life that form our thinking and our pathway as we go forward. I'm Cubish, Cuban-Irish. That means from one small, poor, corrupt Catholic island to another. And I'm of an immigrant family. I was born in the United States by accident and went back to Cuba. And actually, they wouldn't give my family a visa after the revolution because my father was working his way through medical school and the only one in his family that had gone beyond high school. And because I was born in the United States, I was a US citizen, so I think, as my daughter says, I became America's first anchor baby. But it's this country that's given me the opportunities as well as my family to do what we do. And as such, a member of this great society, we have to keep trying to improve it, especially when times like today, where we have such horrible health disparities, where we have outcomes that if you live in Mississippi today, your chances of survival are better if you moved in Bangladesh. If you're a Native American in the United States of America, your lifespan is shorter than those that live in Haiti, including with all the turmoil that's going on. And when I was a medical student, my little sister, who was at my alma mater, University of Florida, wanted to drive down and spend her 18th birthday with me. Well, she never made it. She was killed in a car accident. And you can imagine I was 22 years old, the only boy in an immigrant family, and your little sister dies. And you're responsible for all those arrangements. And you're responsible for, wow, I thought I was supposed to be the one that took care of my two sisters. And I made a promise to God at that time that if I ever got to be a doctor, I never wanted to let anybody suffer or die alone. There's a problem when you make a promise to God. Where are you going to hide? Well, I'm from Miami, and I found City Hall. And apparently, by their policies, God's never visited. But anyways, that drove me in my internship year during a rotation in the ICU. I had a man with biliary TB, metastatic tuberculosis. And they had found him on the streets. It said no address. It meant he was homeless. His date of birth appeared for a much younger person. Turned out he was a Korean War vet and became homeless because he was an alcoholic. And that drove me to go into finding a shelter. Miami, not known as the most compassionate city, had only 2 shelters back in the early 80s. And I went to one and we started a clinic there, and then we started clinics for undocumented, and that started my career along with that as I was doing my training in medicine, GI, and hepatology. The topic today, and I just started to add that up since I'm your substitute plenary speaker, was changing medical education. The way I approach problems in life is, if I want to resolve something, the first thing I do is I look at myself and what I'm doing and what we're doing, and where did we go wrong? Not just society. Where did we go wrong, and what are the systemic things we need to change in medical education in the profession of medicine to really get to true health equity? Well, what is health equity? Everyone has a fair and just opportunity to be as healthy as possible. That sounds really nice. And Robert Wood Johnson took it a little further. This requires removing obstacles to health such as poverty, discrimination and their consequences, including powerlessness and the lack of access to good jobs with fair pay, good education, housing, a safe environment, and health care. You do notice that health care is at the very end, meaning that social and public policies are the main drivers of health inequities in this country and every other country. The social determinants of health, which were originally referred to as the social determinants of inequality, because they affect not just health, they affect education, they affect employment, they affect every single aspect of people's lives. As a matter of fact, there's enough literature out there to suggest that 80 to 90% of all diseases are non-biologic in cause. The epidemic we have of diabetes is not a biological cause, it's not genetic, it's environmental. And all the consequences that come along with it. All the blindness, all the renal failure, all the amputations, all the cardiovascular, the nervous system disorders that come from diabetes originated with something that was completely non-biologic. In medical education, when you teach diabetes, it's not teaching the pathophysiology of what's going on. It's explaining it in the context of the individual's real life. The CEO of an international corporation that's diabetic, you treat very differently than you treat a homeless person that's diabetic. Why? Well, the CEO, you could talk to their chef, prepare the appropriate meals, make sure they get the exercise. A homeless or a poor individual, you can't do that with. And then they have to deal with all the other comorbid disorders that occur. We know that blacks and Hispanics, lower socioeconomics, have higher rates of comorbid disorders at a younger age than an affluent white population does. Health. I'm not talking health care. I'm talking health. And we need to be able to differentiate the difference between health care and health. We need to differentiate the difference between policies that affect health and health care policy. Those are two completely different things. I was listening to a report this morning that 50% of the people on the road are driving dangerously, texting, or not looking. And that right there increases accidents, health consequences of poor social policies. What are the policies that affect health? And I'm giving you just a sampling. Housing, all of education, including undergraduate medical education and graduate medical education, labor laws, discriminatory policies, environmental, business, transportation, climate change, criminal law, police, and a healthcare system or a complete lack of a healthcare system that we have here. So how do we as physicians or medical educators help start making the change going forward? Well, let's first look where we fit in. We help in reforming or creating new policies based on rigorous and appropriate policy analysis. Policy is not advocacy. Advocacy is taking a policy that is econometric in how you measure things and turning around and saying this is what the best thing is. Then to advocate and understand the policies, we got to make the changes. We have to be the leaders in these changes, but just not at a state and national level, understanding that local policy will affect the health outcome of your patient almost more than national policy, because a national policy without the infrastructure at a local level will never be implemented. We need to be able to measure the outcomes of what we're doing. Why? Because it's somebody else's money and it's somebody else's health, and we got to make sure we do it right. What's our end point? To end health disparities. So how do we do this in medicine? Well, first of all, we got to look at medical education. Then we got to look at pre-med requirements. Then we have to look at our own profession. We're racist, we're sexist, we're xenophobic, we're elitist, oh yeah, and we lack virtues. Humility, empathy, compassion. Virtues that become vitally important to be able to drive the intellect to improve the lives of other people. It's not about us. Nobody made you go to medical school. Maybe your mother did, but that's about it. Are we racist? 8% of American medical students are African American. Only 3% of American medical students are African American males. 3.8% of medical school faculty are African Americans. 1.5% of all medical school faculties are African American, and only 4.6 are clinical chairs. Now this comes from the AAMC. So what do you think? Are we racist? I mean, the numbers are pretty clear. Are we sexist? Well, 52% of women compromise medical students, but only less than 19% are clinical chairs. And in a RAND study that was published in Health Affairs in, I think it was 2021, it was showed that women of the same specialty as a man will make an average of $2 million left in their career. Well, we got the first step, right? We're diverse in gender, but we grossly failed at equity and inclusion. So as we talk about all these inequities that occur in society, don't you think we need to fix our own shop first? Don't you think we have to be able to show that within our profession and in medical education to be able to talk about what needs to be done? Are we xenophobic? 6.7% of medical students are Latin. 3.6% of clinical chairs are Latin. There's 4 Hispanic deans in the country. 2 are in Puerto Rico. Are we elitist? The median household income of the 2020 matriculating class was $140,000. That's more than twice the national average, or the median income of American families. 79% of American medical school graduates come from families in the top 2 quintiles of U.S. income. And the disparities are not only economic, but remember, also racial and xenophobic. African Americans, Hispanic, Native Americans need to take out more loans, so they're left with greater debt. At the same time, Holly Humphrey from the Macy Foundation wrote a great piece, little opinion piece called the Social Determinants of Medical Education. And the example was this brilliant African American student at the University of Chicago who had no money to fly for interviews. And when it came time to take his position, I think as a surgical resident at the University of California, San Francisco, had no money whatsoever to move his family halfway across the country. Is this a problem? Yes, this is a problem. And it also shows how elitist we can be. Where did our virtues go? Or did we ever have them? This is a quote from Sir William Osler, 1906. Okay, folks? Over 100 years ago at the University of Minnesota. In these days of aggressive self-assertion, when the stress of competition is so keen and the desire to make the most of oneself so universal, it may seem a little old-fashioned to preach the necessity of humility, but I insist that a due humility should take the place of honor on your list of virtues. We also know by well-documented studies within our own profession that empathy hits the floor after your 3rd year of medical school and rarely goes up again. In a recent study that the Gold Foundation showed, over 80% of American patients, not vulnerable patients, patients, felt their doctors weren't listening to them. They were being gaslit. Is that the type of profession we want to have, or do we need to start looking at reforming medical admissions policies? Is it all quantitative, and we need to bring in the qualitative aspects? I'd much rather have a medical student that minored or majored in the liberal arts because they have critical thinking. They have creative thinking. Everything is not a memorization. Plus, by having that information as an undergraduate that was required in my generation, it was interesting to me for movement is life. You're going to bring a guy in that's almost 70 years old, play college football, and has the worst knees in the world. But that teaches them the world. It teaches them about human beings. It teaches them about stories. What we do as physicians is not all science. The pathophysiology, the therapeutic interventions, yeah, you need to know that. That's required. But that's not going to cure a patient or improve their health, their outcomes. You have to understand all the circumstances that go around. Social and public policies are the cornerstones of health equity. So where do we fit in? Well, everybody in this room has a leadership position. You can advocate for appropriate policy changes. Teachers being paid appropriately, classrooms being the right ratio of students to parents, transportation, living wages, housing. When was the last time you went out and started advocating on those specific issues? Those are the ones that really improve people's health. Those are the ones that really help. Not to be able to have to live in neighborhoods that you were seeing on the screen earlier today, but taking these populations that we refer to as vulnerable now, that, in my opinion, these are folks that we ignore in this country. And we have to stop doing that. I was given a recommendation when I started medical school that take a pad of paper, I guess now you can use your iPhone, but write the interactions down that you have with your patients, the stories. What I tell young medical students is write on a piece of paper the first day of medical school why you want to be a physician. And every time the going gets tough, pull out that piece of paper and read it again. So you can remember why you went into this profession. A profession that we are here to serve. We take an oath. There's very few professions where you take an oath and promise to serve. Police officers, military, people of the cloth, physicians. Well, guess what? We're the only ones that get like a platinum American Express card. So we have no room to complain. It's not like we're suffering economically. I mean, there's some doctors that are richer than other doctors, but there's no doctor that's poor in this country. Ann Case in 2017 wrote a paper called Deaths of Despair. Ann Case is an economist at Princeton who, for the first time since 1917, morbidity and mortality was increasing in this country. And the three leading causes of deaths were suicide, poisoning, and alcoholic liver disease. And guess what? It was all led by non-Hispanic whites, over the age of 45 baby boomers. What was the social determinant that kept them different than the rest of the baby boomers? None of them got beyond an AA in their education. As you can see right here, this was a report that was written by Ann in 2015. See the little red line on top? That's U.S. white non-Hispanic males. You see the little blue line coming down, the dark blue line? That's U.S. Hispanics. Yes, this was caused not by what we thought would be the ones that were leading all this, but another vulnerable population, an uneducated white population that was older. Here you see less than a bachelor's, a BA or more, comparing deaths per 100,000. So what do we do as individual physicians? First and foremost, you advocate for your patient. Then you advocate from where your patient comes from. Then you advocate to make those changes to make sure your patient is healthier. As educators, we really got to relook at how we teach and prepare physicians for the future. We need to start comparing medical education to the health outcomes in this country. It's not how many patents you have, how many papers you've written. It's how is a society's health, because that's what we've been entrusted to do. I mean, I always find it fascinating that when somebody applies to medical school, they write, I want to save the world, I want to take care of everybody. We do a white coat ceremony within the first month of their education. Half of their education is actually paid for through the public dole, through public dollars. They train in a public hospital, or I did anyways, where those that taught you to be a physician were uninsured, indigent patients. When we graduate, we take another oath, talking about how we're going to take care of everybody. And then we become physicians. And what do? Oh, you're not insured? I'm sorry, I can't see you. Oh, no, this is a business I'm running. Well, like any business, you could run it any way you want. But think about that as you drive home in your European car, planning your next vacation or which private school are my children going to. Would that extra 20 minutes really have been so difficult? Could I have spent a little more time listening, been a little more empathetic, compassionate? As an industry, $750 billion has been invested by private equity into healthcare in this country in the last less than 10 years, 9 years. That changes the game. Now it's about profit. Hey, Joe, come on, you're born and raised in America. Everything's about profit. No, everything's not about profit. You're going to lose your business if you don't keep a margin. But how much of a margin do you need? We've been entrusted with the health of individuals, with the health of a country. We have not been entrusted by selling widgets. The physician has to come back to the moral code that we need to do, and maybe that'll help change the industry. The bottom line is we have to change the vending machine to drive it. We could still make great livings, maybe even better. Because if you're using 17 to 18% of your GMP on healthcare, imagine if you drop that down to 10, you use some of the other monies for social changes, and the rest of that can actually go into your pocket. But you did it because people were healthier, not because I did more colonoscopies. Once again, reiterating, get involved in policy change. If not, we're going to be spinning our wheels. We've been in communities for the last 40 years, and Robert Wood Johnson's came out maybe 5-6 years ago and said, we have to go deeper because just being in the overall community is not as deep as like what MIL does, getting in the community, doing programs in the communities. What we did at our medical school, we started this at FIU and we're continuing here, we asked the question before we started writing the curriculum, how do I get to the poorest, sickest patient before they show up at the clinic? Now, why ask a question like that? We have community clinics, for goodness sakes, they can show up. Well, if you're an hourly worker, for you to go to the clinic means you have to take a full day off work, find child care, get transportation, and you don't have any benefit. That means you made 20% less. If you're living paycheck to paycheck, you can't afford 20% less. And even if you go to an FQHC, they have sliding scales. And guess what? If you can't afford that sliding scale, you go to the public hospital emergency room. You lose even more time. Is that the right way to take care of a patient? And then when the patient goes to the clinic and you do any sort of testing and they want a result, you tell them to come back so I can give you the result. By the way, lose another 20% of your income and pay the copay to let you know how your labs all came out perfectly well. So we have to start looking at how we do what we do and the policies that go along with it. As medical educators, just what I was talking about. But medical schools, I believe, have to be measured by their social accountability and health outcomes. The medical school we're working on now, hopefully we'll have our first class in 2025. We have 3 huge community programs that we already at over $1 million a piece each. One of them is we call Genesis. Genesis is household-centered care, where we actually go to the household with an interdisciplinary team, identify, address the social determinants of the individual as well as of all the household members, and mitigate them. We also have assessments that say which is the most urgent, social or medical, and how do we get them to be able to do that. We go into households where there's individuals that don't even know how to use an iPhone or a computer to get an appointment. You can't go through life in this country right now without having that, and many of them live in places that have no Wi-Fi. We have to create 8, medical schools that concentrate on clinicians. We have enough medical schools already that do the bench research. We need clinicians in this country. Not every medical school could be everything for everybody. We have to look at things from a regional perspective. We need to change the face of medical educators, students. You saw the numbers. You saw what's going on. We have to create, adopt curricula that exist in the realities of what we're doing in our country. No longer is it learning about a disease state, but how does a disease state fit in with all the disparities and teaching value-based care? Shouldn't for every case that a student presents, the student has to present the disparities? What are the disparities of diabetes in my society? What are the ethical conflicts that may come around, whether it's from policy or other things going on? What are the social determinants that influence the exacerbation of this disease? But most importantly, what are the social determinants that actually affect my therapeutic intervention? I can do a hip replacement, but if you're in a hoarder household with 7 people, your trip risk is pretty high. I do a knee replacement, but they have no transportation for rehab. That's not going to work real well either. Nor can they eat the proper foods. It's no longer looking at the isolated disease or the organ or just the individual. It's looking at the entire aspect of what is going on. I have 2 stories to tell you that I wrote in a book called Waking Up in America, because I was born here by accident. I published this 25 years ago with Simon & Schuster. 7 people bought it, all members of my family. Most of them liked it. But it was the grouping of all those stories I had written as a medical student, as a resident, as a fellow, and putting them together. I've had great experiences in my life. I've worked in 2 presidential administrations, Bush Sr. and the Clinton administration. I also found out that presidential administrations rarely have a good sense of humor. The first time I met Clinton, we were up here for health reform, and I was at the University of Miami at the time, and we were working in the old executive office building, so we had a white badge with a black A on it. The black badge meant you could go into the White House. They were contiguous without an escort, and we go to meet Clinton, and I was there with the dean and some associate deans from Hopkins, Harvard, and Vanderbilt. You could tell the Hopkins faculty because they would congratulate each other. The Harvard faculty would introduce themselves as God, not the God, but one of the many gods from the Boston area. I introduced myself as, hi, I'm Pedro Greer. I'm one of 4 Cuban Democrats. We meet in a phone booth on 8th Street. And, well, thank you for laughing, because nobody laughed in the Oval Office at all. So I held up my badge. I said, we don't need no stinking badges. So we got into Watergate without these, okay? And in the Bush Senior administration, I was advising with Lou Sullivan, who, by the way, for those of you that are not aware of this, 1985 was the very first time we even had a report on minority health in this country. 1985. I was already a physician. A young one, okay, but a physician. It wasn't until a few years later that it got funded by Congress. And I remember Secretary Sullivan going, we need more minority physicians for minority areas. And I raised my hand, and I remember this was at the Hubert Humphrey building, and I always remember because the conference room had a round table, which reminded me of the Paris peace talks, where it took a year for the Americans and the Vietnamese to decide the shape of the table before we talked about peace. And I raised my hand and I said, Mr. Secretary, Ecomi, my name is Pedro. Do I get like the barrio, but Bob Smith III gets Manhattan? Is that how this works? Or should we not train all physicians to take care of all people? Will we feel more comfortable going into our own communities? Sure. We definitely will. Do we need more ophthalmologists in those communities? Well, with the rate of diabetes, I think we need a pocketful more ophthalmologists. With the higher rates of colon cancer, do they need better screening? Yeah, my subspecialty better start doing that. How about liver disease? With fatty liver, secondary to metabolic disorders and obesity. Yes, we need to start doing all these things. And I write these two stories because for the couple students that I met and some of the residents, write these stories because when you go into practice, it doesn't quite stay the same. It was a Tuesday night at the clinic when a young woman in a tattered red dress came in. She was about 25 years old, but she seemed a lot older, the lines of her battle-weary face barely concealed beneath the smudge of stale makeup. This was at a homeless clinic, by the way. Her soiled clothes, a swath of spandex, told the story of her hard life on the streets in Miami. Her eyes revealed her turmoil. Whatever her story, she deserved a bath and a rest. That night I was working with third and fourth year medical student. I sent Carlos, a third year student, into exam room 2, where she sat weeping. Within minutes, Carlos rushed out of the exam room. Dr. Greer, Carlos called to me in a hurried tone. I can't get a history out of her. I don't know what to do. What's the problem? I said. She's crying like a baby. I can't get her to talk to me. I said, what's your guess? Is it physical? Is it emotional? Is it drugs? I insisted, giving him a signal to follow me. He says, I don't know. He repeated more urgently as we walked toward the exam room. The chart says she's been here once before, some derm problems. No history of psych problems. It does say she smokes crack. That must be the perks of prostitution. Talk about a teaching moment. To take a student to the side and teach them how not to judge. Number one. Number two, to explain to them there's nobody in the world that wants to be an addict. And I'm sure there's somebody in their family with a substance use disorder. I stepped into the room and found a desperate woman. She was trembling. I extended my hand to greet her. We're here to help you. Do you hurt somewhere? I asked, gently nudging her elbow to give her a sense of stability. She was full of tears, gasping for air. It hurts down here, she said between sobs, holding her lower abdomen and doubling over. It feels like it's burning, Doc. It won't stop. Please help me, please. The nurse and I let her calm down a bit before we examined her completely, and as I palpated her tender belly and examined her further, I concluded that her symptoms in the exam suggested a mix of pelvic inflammatory disease and other sexually transmitted diseases. It'll be okay, I told her, trying to offer her a little reassurance. Slowly, she began to tell me why she had really come to the clinic when she could have gone to the gynecologist at the public health unit. I was raped. Raped hard last night, she said as she doubled over in tears and in shame. Why didn't you go to the Jackson Memorial Hospital Rape Treatment Center? I asked. It's one of the best in the country. And it was just maybe a mile away. Doctor, she said with a look that suggested I should know the answer to my own question. Look at me, she said. Look at how I'm dressed. She paused and then she broke into sobs. I couldn't take the comments that people would make. She was right. We have this mammoth system of healthcare that can offer excellent medical care and all of the best technology, but it offers no solace, no empathy, no protection from prejudice. That's because in whatever edifice we construct, there's a gaping error in its construction. You can't build a heart. No matter how advanced the system lacked, what that young woman needed that day, compassion. And why is that important? Because each and every person in here in their leadership role becomes the heart of the organization they work in. The message that they have to send. This is why we are here. We are here to improve the lives of others. People who suffer in ways we could not imagine. Things that happen to people that they never talk about. That's the compassion and the empathy of being a physician. And the humility of knowing that we're just lucky. We didn't have to grow up there. We had the opportunities. We could give those opportunities to our children. But you know what? we can give those opportunities to every single person so that they can do something about it. So yeah, one of the most important lessons in my life was taught to me by a homeless woman. How to look at our system, how to see what is going on, and how to evaluate my own values. What is it I want to do with my life? Is it just about the car? Is it just about where I'm visiting or the size of my home? Or is it truly about making this world better? Because there's nobody in this world that has the passion that those of you that are sitting here today do, and so many other organizations, and going out and do that. You have that opportunity. But let's look at ourselves as we go through this and say, where do we need to change? What do we need to do differently to improve the lives of those? Because I think about this and I think about, wow, if my father hadn't had opportunities, he'd be driving a cab just like my grandfather, or working the laundry room at a motel on Miami Beach when they came to the United States. One afternoon around lunchtime, I walked into the homeless clinic with a sandwich. I greeted the patients in the waiting room, walked over to the pediatric area. We used to have a PD room for the homeless kids with a glass door so the mothers could sit outside of there and just relax for a little bit, and we had volunteers with the kids in there with toys and all that stuff. Where I found a mother with 3 of her children. They told me they had come in from the Salvation Army shelter. Her youngest child caught my eye. He was about 6 years old, a little boy with a sweet smile. Well, I'm Catholic, so I have a natural sense of deep guilt. And so you can't walk into a clinic at lunchtime that's homeless with a sandwich and eat it. You know, and plus me, I'm a non-purging bulimic. And so, and do you ever think about what it's like to be a homeless child? Do you ever think about that? First of all, you don't have stuff. I have 2 kids. They have their stuff. They're 3 years apart. If my son found a toy that my daughter hadn't looked at for 4 years, she wanted it back right away. That's my toy. When you're in a homeless shelter, if you're lucky, you have both parents. If not, you have one. But you're in an 8x12 room. For those of you that are parents, if you put me in an 8x12 room with my little 2 kids, I'd be institutionalized on Monday when I walked out. They don't have family dinners. They have shelter dinners. Where can they express what has gone on in their day? When they go to school and they say, draw me your house, what do? Draw shelter? We say there's opportunity for all kids in this country, not for the poor kids. Who's helping them out with the SATs? Who's instructing the parents on how to help them to do these different things to give them those opportunities? I offered him my bag lunch, which he graciously accepted. He took the sandwich out of the bag and split it in half. He took 2 bites out of one half and slipped both parts back into the bag. Then he carefully folded the bag and put it in his pocket. Why'd you do that? I asked him. I mean, here I have, I did 3 postdoctoral fellowships. I did my residencies. I had Nobel laureates as professors. Didn't understand a word they said, but still had as professors. And here I am with a little homeless child and can't figure out what he was doing. Why'd you do that? His reply stunned me. It's for my brothers, he said, very upbeat. He was hungry, but he knew his brothers were just as hungry. My God. Here's a little 6-year-old homeless kid that's teaching me by example how I should be in a society. Really? You're thinking about somebody else while you're hungry? I come from Coral Gables in South Florida before I moved out to Vegas. And, Coral Gables is known as the city for the financially gifted. If somebody were to bring in a sandwich and give it to somebody in my neighborhood, they would hire a tester. And if the tester was still alive, they might consider eating it. Here's a little boy who has nothing, and is thinking about his siblings. God has allowed me to study medicine to explore the depths of disease and its treatments. God has given me the most brilliant professors and inspiring mentors. He has opened the tombs of healing and placed in my hands the most precise instruments of modern technology. And on any random afternoon has extended the most remarkable postgraduate opportunities. He's allowed me to find him in the gentle lull in the city of Miami, under a bridge in an emergency room, in the waiting room of a neighborhood clinic, in the wisdom and humanity of a homeless child. The goodness of that child has stayed with me throughout the years, and I have often asked myself, could the lesson of that child's generosity be multiplied by a community, by a government, by an entire nation? Could such a spirit help bend a broken system? In my morning prayers, I always pray to be that 6-year-old child, to be able to go through life without judging others, but using all the tools that have been given to me to improve the lives of everybody. It's our communities, folks. It's our country, and it's the world. It's all ours to make better. Nobody can take that away. My recommendation is set the bar as high as possible. Set it so high that we don't reach it, but we never stop reaching for it. Together we can save the world. Martin Luther King once said, of all forms of inequality, injustice in healthcare is the most shocking and inhumane. Our lives begin to end the day we become silent about such things that matter. And Dick Gregory, who I grew up loving, the greatest nation is the one with the healthiest people. Let's be the healthiest nation. Thank you. Thank you. We're going to do
Thank
some
you,
questions.
Dr. Greer. Yes.
Okay.
But before we open it to the audience, tell us what took you to Las Vegas and what are you aiming to accomplish there to increase equity and diversity in the healthcare professions?
What took me to Las Vegas was I was looking for a city more intellectual than Miami. Actually, what took me to Las Vegas, and I had been offered various positions, was I was looking for a place where we could start with a blank slate, to bring in the best minds that I knew, to sit down and develop a curriculum that could make a difference in a region of this country that ranks 49th in ratio of physicians to patients. There, we have some of the highest maternal mortality rates, suicide rates, substance abuse rates, and so a difference could be made. We have a program that we started that we've just now, is going to be going on all through Nevada and into Utah, which is called Empowered, which is for opioid and stimulant use disorder pregnant women and recent mothers. That was a niche that nobody was looking at. And the question is, why are you doing that at a medical school? It's social accountability. The students have to have the example of seeing this. Mental illness, substance abuse is such a huge problem in this country. What am I going to do? Give it to them in a 4-week lecture? Or let them see the ravages that occur when this disease is left untreated? We have Genesis, the household-centered model. We've developed an app with Apple engineers to follow social determinants. We have 10 domains on a monthly basis, and we follow social determinants as we follow any other disease. And then we're hoping for, with AI and predictive analytics, to be able to use social determinants to let us know what's going to happen to specific diseases and how aggressive we need to address those at the moment. Not just the disease, but the cause of it. And I promise everybody beachfront, no ocean.
Before we move on, Dr. Greer, how easy is it to change medical education?
It's easier to resolve the Middle Eastern problems.
Oh.
Medical education, in many ways, is a battleship in a swimming pool. You know, it was interesting. We consulted and helped start a few medical schools around the country, University of Texas, Kaiser, Cleveland State, but they were from scratch. When we were going to legacy schools to talk about curricular change, what do old academic physicians say? Well, it worked for me. But it's not working for me. It's working for the people that we're supposed to treat. Yes, we have all these great patents and technology better than anybody else, but the health outcomes are horrible. And actually, it was at George Washington where the then chairman of surgery, or orthopedic surgery, and you orthopods will love this, that actually was the only one that really got social determinants. And we were, after my third or fourth day there, I was sitting with him having coffee, and he said, you know, I get it. I didn't go into orthopedic surgery to amputate the legs of diabetics, but that's what I do the majority of the time. He understood it because of that perspective, which was true. So there's one way, either move the mountain or build your own. So we decided to go to Vegas. I mean, who's going to think anything intellectual is going to come out of Vegas? That's number one. Number two is I'm not weighed down by the anchors of tradition. We could look at doing things differently as long as we fit within the LCME, and then it's a Trojan horse type of thing.
What would you say is the biggest challenge in trying to change medical education?
Faculty development. I think that's the hardest thing. And also teaching doctors how to teach. You know, that's the other thing that's important. Nobody taught us how to teach. But also you have to have diversity at the senior level. Of the 6 of us that are senior deans at the medical school, only 2 of us are males. One's African American and I'm Hispanic. 3 are African American. 4 are women. But what's most interesting in the diversity that we have, only 2 of us have MDs. Because if you're going to really integrate into the system, you bring in your clinical faculty, of course. But as you develop the curriculum for undergraduate medical education, if I don't have a bioethicist, if I don't have an expert on diversity, how do I appropriately set the curriculum? Just through the eyes of a doctor? Or do I set it through the eyes of how do I improve our society so the doctor has all the tools to do what they need to do? And so that was the other thing that we did. So.
Okay, so now we're going to go to the audience. Kind of hard to see. Dr. O'Connor, you have a question?
Thank you. That was just amazing. I loved your whole concept of, I'll use the term maybe experiential learning, right? Where the students are experiencing what their patients are going through more so, or seeing it. I mean, it's more tangible to them. And and I thought about an experience I had back when I was at Yale. I brought a psychologist over to help with chronic pain patients at the spine center. And then one of the hospital administrators was concerned that just wasn't financially positive. You get the argument, right? Where we're showing these great outcomes, integrated team approach, and then they silo in on this one provider and want to tell me that I can't continue that. So I, of course, was very upset, got my Irish up a little bit, Dr. Greer, right? But here's what I did. I actually made the hospital administrator that wanted to cut this position go over to the spine center with me, got permission from some of the patients to observe one of these group sessions. I said, this is why we need this person here, okay? Like, these are the people that need this kind of support. And if you think the orthopedic or neurosurgery spine surgeon is going to provide this, that's not happening.
Right.
He backed off. So, no, I mean, besides, I'm like, hey, I am demonstrating financial value here. Like, now you're trying to squeeze more. You want more by cutting this one component that you think is not profitable instead of the bigger picture, which shows that we're doing well financially. But that's, again, the mindset of people that just see things very siloed.
And long term.
Yes, but it got me thinking, like, can't we take that same kind of concept and broaden it? What if people that are developing, housing communities, do they go out and actually look and experience where underserved people live? I mean, I don't know. Maybe that should be part of like architectural school training. Maybe this whole concept of trying to get young people, when they're learning their skills, exposure to these challenging situations that we collectively need to come together to solve will help us. So not just in medical education as you're doing, but broader across multiple sectors of education.
I agree, 100%. I also, the other thing that I'm doing is I'm targeting first-generation college students for various reasons. Number one, they tend to stay. They're the first ones in their families that earn generational wealth. Number two was the experience I had at FIU. Since we were a whole new startup, the very first new startup in 25 years in this country, 70% of our students only got into FIU. 30 to 35% were first gen. Every graduating class we had when we left in 2020, we opened in 2009 and had our first graduation in 2012, had the highest step one pass rates and scores of the entire state of Florida. And when I left FIU, we still had 100% match in ophthalmology, neurosurgery, and urology. And with the exception of one student, we would have had 100% match in orthopedics too. Now for a startup school, this is amazing, but what we did was we were so deliberate in faculty development and how to prepare these students, which had taught me something else. We're throwing away talent. If you can graduate the highest in the state, but they're getting rejected everywhere else, what are we doing wrong? What are we not looking at? And you know, I've had people tell me at a national level, oh, so now, you know, the blacks and Hispanics that you wanted to go back to their neighborhoods, now they're going to become ophthalmologists and neurosurgeons. And I said, yeah, they earned it. What makes you think they're not going back to their community? Or is the deal set up that if you're black or Hispanic, you get the FQHC as a primary care doctor? So we need to change our internal thinking and a lot of the things that we're doing. And even in admissions, I think there's a lot we have to do differently. And I think that there's a lot of pre-med courses we got to get rid of and a lot of other ones that we need to put in. I'm a big believer in the liberal arts. I'm a big believer in that basis it gives you of knowledge of how the world is and how the world was, so you could better take care of your patients. Because it's not just the disease state. Is this a bigger burden for us? Yeah. But we get reimbursed pretty nicely.
Thank you.
So take that burden. Thank you.
Please, question.
Hi. Dr. Greer, thank you so much, not just for your presentation, but for being on the planet at exactly right now.
Oh, thank you. Talk to my wife. After 43 years of marriage, she tells me it's the best 2 years of her life.
Bless you. Micheline Davis from National Medical Fellowships, and you have been singing my song because what we do is advance diversity in medicine, as you are well aware. Thank you for your prior partnership. I love the fact that you were talking about the impact of policy in, quite frankly, addressing the social determinants of health, right? For those of us who have been in this space, really addressing it as the political determinants of health for such a long time, long before our friend Daniel Dawes wrote his book. I'd love for you to just speak to us for a moment about the key importance of why it is and how they can, for physicians and healthcare systems to really take the lead in impacting policy in order to address the political determinants of health.
100%. There's a couple things we're doing. I've been working with the RAND Corporation, with the graduate school, on teaching policy analysis 101 to medical students so they understand what it is. But once you're out there practicing,
Huge.
It requires a few things. Get involved with the leaders that are making change. Support these leaders. Write checks. We can be a pretty cheap profession.
Yes.
It takes that, support candidates that support the issues that we need done. But look at them carefully. Talk to them. Because of who you are, you have access to these individuals. You have more influence than you think you do. But study these things carefully. See what is the most important change you need to do in your local community, because that's where you could get a lot of policy change to really help out, and then go state and national. but you have to be active in that arena. What I tell most of my compadres down in South Florida is the first thing you got to do is start thinking about switching parties. Okay? It's not about socialism. It's not just one issue. It's a variety of ongoing issues that have to be addressed. And we're the leaders in our community because society has designated that physicians would be leaders, that we have to take that lead. And we have to do it for the right of our patients to improve their lives. But be careful. Look at policy analysis. Make sure it's the right, appropriate policy. But make sure whenever you fight for a policy that is being measured correctly to make sure that it's being as effective as you want it to be. It's a whole new role we need to take on, folks, but it's our country. It's nobody else's. We can make it what we want, and we can give the people the opportunities to succeed in our country. And by targeting first-generation students, I also get, for the first time in that student's family's history, somebody will be able to earn generational wealth. I mean, they're not going to be Bill Gates, but guess what? You can own a house. You could pay your kids college. You could do all these different things. But policy, to me, is ultimately the most important. Thank you for the question.
Thank you.
And thank you for what you're doing.
So we may have time for one more question. Dr. Jimenez?
Yes, thank you very much, Dr. Greer.
Yes, sir.
My name is Ramon Jimenez. I'm one of the other Latinos. But I'm born and raised in California. Parents came from Mexico 100 years ago. But just a couple of comments. One, not to improve on your comment, but I've been married 56 years, and I describe it as bliss. It's kind of gone by like 5 minutes underwater. So my wife is going to kill me when she hears me. But the other thing that I really want you to comment on, it may not be entirely in your bailiwick, but corporate medicine. And there is a empathic Irish cardiologist in Monterey County. Patients came from all over to see him. Great doctor. But he was Carmel, and that hospital has become taken over by corporate medicine, and to the point where they put a alarm clock on his exam room door, and if he went past 14 minutes, it went off. So he told him what to do with the alarm clock, and he went over to the county hospital, where he's very good. But the issue of corporate medicine, what are your thoughts?
My thoughts are, it's becoming more and more corporate every minute. It's, as I had mentioned earlier, $750 billion in private equity investments, which means that it's no longer about health outcomes, it's about economic outcomes. So we have to build, if this is the way we're doing, either look at policies or build protective measures to make sure that the doctor still has the autonomy to do what they need to do. And it's not a volume issue. It should be a health outcomes issue. And that's, I mean, there's a whole lot of ways to look at corporate medicine. You have the not-for-profit world with Kaiser Permanente and Geisinger, which have now joined and do, value-based. They have their problems too.
Sure.
You have the HCAs, which are now the #1 providers of residency slots in this country, overtaking the VA. However, what HCA does, and I've seen some of their programs, which are really good, the ones in South Florida are not, is that a resident's a lot cheaper than a PA. And what I saw in another hospital system was, it was a for-profit system, so for their primary care, they had no continuity clinics. If a patient had Medicaid or no insurance, they weren't followed. So we have to have closer vigilance by the ACGME, looking at what's going on with that to make sure, because these are the corporations that are doing all these things. So I think your question is invaluable. I wish I was more knowledgeable in that area. I'm just as unhappy with it as you are.
Thank you very much.
Thank you.
Thank you, Dr. Greer. Please, another round of applause.
Thank you.